Hello everyone. This lecture is on renal failure to add to our advanced med surg lectures, and I want to introduce you to, hang on, let me get him. Shorty. This is a guy that was barking in the background in one of the other lectures, just to torture you. He's soaking wet because it's raining outside, and I can't think of a better day to discuss renal failure than on a wet, rainy day with a wet, soggy, shivering dog. Anyway, so renal failure. You've already had pathophysiology lectures on acute tubular necrosis, management of patients pre-total failure. You've had some introduction to this also in your previous med-surg classes. Please review the A&P for acute injury as needed in SOL. I believe those are pages 432 to 50. Read 450 to about 59 for this lecture. Iggy has chapters you should review 67, 68. Certainly heavy read 68, and 67 should be more of a review. Anyway, kidney failure. Hopefully this is a building on what you guys have already learned. So, as a reminder, acute kidney injury, commonly AKI might be referred to as, or end-stage kidney disease, ESKD, are common lettering you might see. So what is it? Reminder of some of the definitions you should look up and be comfortable with. Deterioration of renal function, oliguric and uric. Some of the definitions here. Oliguric is urine less than 400 milliliters per day. So when we're doing your total, your INO, part of the reason we look at the 24-hour INO, it's a measurement standard you can look at from day to day. Polyuria is proteins entering the glomerulus and takes fluids with it. So you may have I remember I had this kid in a particular rotation who was diuresing like crazy. You're thinking, oh, his kidneys are working, but no, they weren't. It was a stage of his end-stage renal disease. And because he could no longer filter and retain the proteins, so we're having to give him albumin to compensate for that. And uric, think of that Latin, that's easy to remember, no urine output. Dysuria, painful urination. I remember in nursing school, I don't know why it sticks in my head, when I first learned the word diuresis. And I remember it was just so exciting. I learned a whole new word, a whole new Latin language started coming into my world. And we had to diurese after drinking a big glass of iced tea. We started using it in our everyday language with our friends. I remember on the beach with my beach, meaning Theta Beach, which is this little cement back patio by the sorority house that we had put paint on it, and we called it Theta Beach. And I remember one of my girlfriends, I'm like, instead of pass me the suntan lotion, I'm like, I need suntan lotion on my lower extremities. And she was a nursing student. She was like, really? Do you guys have to talk like that all the time? So it's fun to learn these words and then use them. Like, I have to nicturate, meaning I have to go to the bathroom. Anyway, so ozytemia, accumulation of nitrogenous, if I can even say it, nitrogenous waste, meaning your kidneys aren't clearing out the toxins, they're retaining the toxins. And certainly acid-base disturbances, we've talked about that in a variety of ways, and the kidneys are your big buffer system. So what happens? You're going to have fluid overloading, electrolyte imbalances, and certainly renal replacement therapy may be required. Oliguria, as we said, was a low urine output at those end stages when you're still, and when you end up on dialysis. Typically, you worry about potassium because it can get elevated because your kidneys can't clear it properly. Sodium issues, phosphorus issues, these are the three biggies people need to pay attention to, and protein. So hopefully that should be a review. What are some of the findings we find in the end-stage renal failure patient? Patient's general appearance certainly is assessed for signs of uremia. Okay, so uremia is actually the retention of nitrogen substances normally excreted by the kidneys, but it gives you these things you can actually assess for. So they have horrible malaise, fatigue, sometimes disoriented, drowsiness. You just feel like dirty poo-poo. And you'll see so many people as they go into renal failure or they're on dialysis, they just can't work anymore. It's just, the description for patients is just this, I guess, what's the best way to describe it? Maybe how crappy you feel when you have the flu, and maybe these, without the fever, you just feel that draggy feeling. I think they feel this way all the time. But they got to keep going. Certainly your skin can be pale, yellow, and dry. Part of that, the nitrogenous substances circulating around, they're not getting out, so they end up in your skin. And then certainly they're fluid overloaded because they're not able to urinate out the volume they need to urinate out. Hypertension is very common. Your kidneys, if you remember, they have the sensors on them that that produce erythropoietin. Hypertension. I'm moving on to anemia. Hypertension, your kidneys sense flow. Okay, and part of the reason they retain or release fluid is the flow coming to them, so they get an idea that you need volume or you don't need volume. So there's sensors on your kidney that sense, you're upright and the volume going through them. But if the volume's not coming through them properly, they're not sensing it, so they think I need better flow. So they chronically tell yourself that you need better blood pressure, creating hypertension because the sensors aren't sensing the proper flow. So it's not independent hypertension, it's the kidneys creating the hypertension. Then heart failure, certainly there's a uremic toxic effect from the volume of the fluid, overloading and stretching. The toxic effect of the nitrogen waste, but also chronic high volume, overstressing the heart. And then of course more high volume because you end up with a hypertension. Anemic, that when I started to, again, there's little sensors on your kidneys that tell you to produce erythropoietin, and they sense flow. So if they don't sense proper flow, they don't tell your kidneys, they don't produce, which tells the kidneys don't produce, telling your bone marrow to produce red cells. So it's a trickle-down effect, basically, from not proper flow to your kidneys. Since you're anemic, you end up with bruising, petechiae, and edema. It's interesting because we're able to treat this better than we used to. When I started nursing school, before we could actually give people erythropoietin, the anemia was so chronic in these patients, just miserable. And we had one guy that was Jehovah's Witness, and so he didn't want a blood transfusion. So he was so proud that he was able to live as long as he did with this horrible anemic state. And we were like, wow, poor guy. Anyway, encephalopathy, they say renal failure is not a bad way to go, if you're going to die, because you basically just get confused and go into a coma. And if your kidneys shut down completely, probably about a week you'd be dead, sometimes faster. So they say it's not so bad. You don't suffer because you don't know you're suffering. And then pericarditis, volume, fluid, stretching, irritation. I think that's it. Oh, and of course, iron and folic deficiencies. That goes with the anemia. And we talked about that. So if the platelets aren't functioning well because your bone marrow is not producing, then you also have poor platelet function. So it's an increased risk for bleeding. Okay, so that's just an overview. But what about some of the laboratory findings in this crowd? You should have been introduced to most of this, so this should be a review. Increased creatinine. We know the normal is a fairly low number, 0.5 to 1.2. Creatinine doesn't jump up. Potassium, I can give a bolus, I can change it very quickly. Creatinine doesn't make big leaps. So you'll see as you're following your patients, you're looking for trends, and you'll see it creeping up, and creeping up a little more, and creeping up a little more. 0.12 to 0.14. That's a big leap. So you're looking for small changes in that. BUN, blood urea nitrogen, 10 to 20, same thing. Now this creatinine BUN, you'll see them tracked together. BUN, more of a change if there's also muscle damage in other areas. Creatinine, more kidneys, but the lab test is drawn together. It's not an expensive lab test. But you're looking for those trends and a slow increase daily. And you'll see much higher numbers on chronic dialysis patients, and they'll tolerate numbers that the healthy individual wouldn't. They'll have higher potassiums that somebody else might be having arrhythmias with. Your body's amazing what it can adapt to. It chronically adapts to these what are unusually high numbers on a normal healthy person, which we panic about and we tolerate and don't bat an eye at in the chronically ill dialysis patient. Blood osmolality, there's a normal there, 275, 295. Glomerular filtration rate, this is a popular one to follow, meaning it's a good indication of renal failure. The normal is 80 to 125. We start worrying about you getting in trouble at about 60, that you're in failure. And dialysis is basically, the magic number is about 15, end-stage kidney disease around 15. For example, my mother's 87 years old, and her GFR 6 months ago was 30. And she's fine. She's eating whatever she wants. She's drinking. She's tooting along around the house. She's senile, but she's completely functional. You can function, quote unquote, normally with up to only 10% of your kidneys still functioning. Okay? People lose approximately 10% of their kidney function every decade, meaning every 10 years after age 40. So it's normal to slowly lose off kidney function as you age. There's a reason you got 2 of them, and they're very resilient organs. You can still literally function with only 10% of them. You couldn't function with only 10% of your heart functioning, or 10% of your liver hardly. And your specific gravity, this gives us an idea of the concentrations of solute of urine. So as you know, when you haven't drank much and you urinate, it's dark yellow. Or if you drink a whole lot of fluid and you urinate, it's watery. So that's your concentration. You can see it and know it's dilute, and this is numeric value to get the idea of the dilution. And certainly metabolic acidosis. We know your kidneys excrete hydrogen, ion, and decreased production of ammonia in the kidneys, which normally assists in the excretion, doesn't occur. What else is important? And hyperkalemia, big one, really important. Your kidneys can't excrete the excess potassium that it normally would. This one can be critical quickly, and typically these patients get tolerant though. You'll see patients with a 3.5 to 4.5 is normal for potassium, right? And so I would be in trouble with like a 6, and you'll have a dialysis patient just chronically about that level. But acute changes, very dangerous, and it can change acutely. Sodium, you change it slowly, and it alters slowly. It's dangerous to alter sodium quickly because it can cause your brain cells to swell. Potassium, you can handle bigger shifts. Okay, so now that was overview. Certainly you need to review the chapters to get more details. But a little bit about dialysis. Dialysis literally the movement of fluid molecules across a semi-permeable membrane. So they call a filter the kidney. It's from one compartment to another. It's causing a shift used to correct not only fluids, but also it helps with electrolyte imbalances. It's not perfect. These patients do never feel great, but they're alive. They would have died at a rapid rate without it. So it's a bridge. It buys time. It keeps people alive, but it's not curative in any way, not even on the short term. It removes waste products in the renal failure patient. You can use it to treat drug overdoses. Pulls out medication. So one of the things you may do on these patients is their orders may change, whether you give their hypertension medicines or not. A lot of times you don't because their blood pressure is going to drop during the dialysis. You may give it afterwards. And dialysis filters stuff out. So it might not be useful to give certain medications before dialysis. You hold them and give them after dialysis. Or you might not get the benefit. The other thing is you watch, you're taking care of a patient, and you see they're going into renal failure, or watching their creatinine and BUN go up over days. It might be useful to have the conversation with whoever the attending physician is to lower the dosages of certain medications. Because if they're cleared by the kidneys and you can see the kidneys failing, then you need to adjust the dosage of the medications relative to their ability to tolerate it. So you can treat drug overdoses, remove waste products, correct fluid electrolyte imbalances, and it acts as a literally plastic filter at the bedside. And, of course, there's a page in the book, I think it's 451, that talks about hyperkalemia treatment. So you can actually lower the potassium level and regulate it through dialysis. Okay, so a little bit of the general principles of dialysis here. Literally, it's called a hemofilter or a kidney. You'll see people refer to it as. It's a semi-permeable membrane. And here's just a graphic depiction here. On the picture, here's the blood going by and things that can be filtered through, sucked out osmotically with the dialysate. So, two principles: diffusion, which is the clearance of waste products. Here you go, urea, potassium, creatinine, hopefully not the red blood cells, and water may go out. Okay. Then ultrafiltration is the removing of the plasma water, which is the water going out. Use pressure and osmotic gradient. So you want to diffuse waste products and ultrafiltrate water. What else? Ultrafiltration is actually the removal of plasma water and some molecular weight particles by using a pressure or osmotic gradient. Okay? Diffusion, by definition, is the movement of solutes, such as urea from the blood, to the dialysate across the semi-permeable membrane. So in the case of hemodialysis, the semi-permeable membrane is the hemofilter on the machine. Okay? In peritoneal dialysis, the semi-permeable membrane is your abdominal membrane. So ultrafiltration is aimed at controlling fluid volume, whereas diffusion is aimed at treating fluid and electrolyte imbalances. So they're doing what looks like the same thing, but really two different things. Okay, a little bit more about dialysis. There's different methods of dialysis. There's hemodialysis, or you'll see it charted as HD. Typically, the person's hooked up, as you saw in the earlier picture, and I'll show you another picture of it in a minute. It runs 3 to 6 hours, and it's an IV event, intravenous event. Peritoneal dialysis, or you see it charted PD, is literally infusing dialysate in your abdominal cavity. It dwells for amount of time period, and then you drain it. So it should pool toxins and fluid in with it because of the osmotic changes, and then you drain out the difference. Continual renal replacement therapy, CCRT, is another IV version of hemodialysis, but instead of episodically, it's running around the clock. And this would be more of an intensive care unit thing. Hemodialysis is literally long plastic cartridges that contain thousands of little parallel hollow tubes or fibers. And these fibers are create the semi-permeable membrane. And if you go back, you can see in this picture here in the background a kidney filter. And the machine, a centrifugal pump, pumping it around. Okay, so here's some more pictures. So how do we get to dialysis? What do? We have to have vascular access, right? So a percutaneous catheter, which is an example of the Hickman we talked about under central lines, literally short-term use, could be the jugular, the clavien, or the femoral. Again, you do not draw labs, and there's nothing infusing in this particular port. It's literally set aside for hemodialysis. They don't want to risk it clotting or have any issues with it. And a fistula, picture B here, and you can see where this is the person's human artery and human vein, and they've been anastomosed. Okay, so you're creating a fistula on purpose. Usually it's the radial artery to the cephalic vein. That's the most common. Certainly if we want to keep people alive as long as possible, start most distally first. Bypassing the little capillary beds, putting the main artery and vein together, and it because of the high pressure, it will create a larger vessel going through it that you can cannulate easily. So this is a surgical procedure, and it takes 4 to 6 weeks to mature before it becomes a larger vessel and can actually be used for dialysis. In these fistulas, you should be able to hear a bruit and palpate a thrill. So you put a little stethoscope on there, you can hear it, and you can feel it. The hand should stay warm, and there should be a decent pulse. So part of your assessment is the bruit, the thrill, which you learned in your assessment class, and the warmth. What else? Now, sometimes there's a graft. Here's a picture of a loop graft. Grafts are prosthetic materials, Teflon, surgically anastomosed between the artery and the vein. Needs 2 to 4 weeks to heal. When have I seen that? We had a girl, I'll probably tell the story over and over again. It's so interesting. Placentia abruptio with her baby. She went into ARDS, ended up in the ICU, and went into renal failure because she, and I'm sure I mentioned this under the DIC story lecture, because she's a classic example of multiple problems that occur in a normal, healthy situation, and her kidneys got clotted off with little microclots. So she went into temporary renal failure. So we wanted a temporary access. Put in a fistula, we put it in her ankle, and because she was in DIC and not clotting, and we had to use it right away, it would fall out once in a while. You shove blood everywhere, shove it back in really fast. It's amazing how quickly your body normally heals around things. And it would, as you know, if you cut your finger within 5 minutes, it quits bleeding, right? But if you're in DIC, it doesn't. So it's so interesting that this patient, it was dangerous, but it's all we had. We had to do something. And she actually ended up surviving and did okay. But she had an external loop graft. Now here's a picture, another kind of graphic picture. Here's somebody taped up with their dialysis. You can see it's afterwards, so you can see it's pink. So they flush the lines. They're just about to discontinue here. You can see old scars where they've had previous fistulas for the patient. And then here is a radial site. This is just graphic. And you have to have a centrifugal pump, which isn't normal. Your body normal has a pulsatile pump, and now we have a centrifugal pump. There has to be heparin to keep it from clotting in all the lines. Okay, here's your dialysate, draining in and out, and here's the hemofilters. Then it goes back to the patient. Now, during dialysis, typically you need 2 needles, 1 pulls, 1 returns, set it's heparinized. You have to monitor the vital signs closely. It's a large volume of blood. Temper it out of the patient. They can drop their blood pressure. It's a precarious time period, so patients have to be monitored closely. So generally this is only done by an extra nurse that's sitting with the patient the whole time in the ICU. So you may be caring for the patient at the bedside while those dialysis nurse is sitting there monitoring the patient during the day. Like I said, it's 3 to 6, 3 to 4 hours, somewhere in there. If their blood pressure tolerates with fast removal, so they may have to go slower or do a shorter treatment if the patient doesn't tolerate it. Poor cardiac function, they might not tolerate it, and certainly they can have arrhythmias from the rapid shifting of the volumes. Pre and post dialysis, certainly you draw labs to see where you're at, and you weigh the patient, and we get fluid off. Typically you hold those antihypertensive meds beforehand because their pressure is going to drop on dialysis. And you're always monitoring for complications. One of the, certainly volume depletion, they can be very hypotensive afterwards. So they're never just gotten up and sent out the door right away. And certainly in the ICU, you're monitoring them all the time. Arrhythmias can occur. That's one of the risks. Hypoxemia. And this thing called disequilibrium syndrome. It's occurrence of neurological symptoms. They think it's cerebral edema during or following shortly after hemodialysis, because you have these huge shifts of fluid, and they think your brain sometimes is irritated by that. Usually people adjust and they get used to dialysis, so it's usually after this early on when they start dialysis, about the second treatment, typically when you might see that. Dialysis can ease many of the symptoms of renal failure, but not all of them. Certainly there's always a risk of infection of the vascular access. We're sticking needles in there, it's an exposed site. Muscle cramping can occur afterwards because you're pulling out a lot of electrolytes at once. Loss of blood, as much as you're giving it back, you lose a certain amount every treatment in the tubing. As you could see the picture before, it's pink. You lost a certain amount of red cells. And then you had to give them some volume back to flush it. Not only that, look at that centrifugal pump. It's smashing and breaking, damaging red cells in the process of trying to help you. A certain amount of sticks to the plastic tubing. platelets and stuff on the inside. So it's certainly not perfect, but it works. And certainly graft infection is a risk at the site, and of course massive sepsis is always a risk. So you can prevent certain complications, certainly death, which would have occurred without it, but you cannot fully replace metabolic and the hormonal functions that the kidney's involved in. So that's an overview of hemodialysis. It allows people to live way longer than they would have. It is a miserable existence. You'll see a lot of the geriatrics, people over 65, and of course the younger group, we'll get into it in a minute, we attempt to transplant. Continued renal replacement therapy. This is hemodialysis, the same sort of setup, but in a patient that can't tolerate episodic 3 to 6 hours with the large volumes. The critical patient in the ICU may have continuous renal replacement. I had a child, was a good example, it was a small child. I can't remember, she was probably 5. I had her on CCRT and used the 2 femoral sites, one in, one out, to give her the continuous dialysis, so it's a slower, constant pulling. So if you're too unstable on hemodialysis, you may use CCRT. Same concept, hemofiltration, ultrafiltration, and diffusion. This is just a graphic depiction on the side here, but it's gentle and continuous, so you get a more gradual solute removal. When you feel the tubing, it should be warm to touch. The dressing change is sterile, you're very careful with that. And certainly the ultrafiltration coming out should be yellow. It should be clearing stuff. It's generally set up and started by the dialysis nurse, but the bedside nurse continues to manage. This was kind of scary because I don't feel like a dialysis nurse having a patient on this, but the bedside nurse actually manages it. Other advantages is flexible fluid administration. So with a hemodialysis patient, their volume fills up for a couple days and then you drain it out. So this massive up and down thing that goes on. Whereas here, it's you can continue giving fluids at a more moderate rate. Mineral heparin required. We said it can be done by the RN, and electrolytes are adjusted more slowly. So it's a little less dangerous. Certainly disadvantages, this person has to be laying in the intensive care room, not moving. And it is a one-to-one nursing care because they're so critical. And certainly, on top of it, it would have been a very critical patient anyway, because they didn't tolerate hemodialysis. So this is just, the next slide here is just a picture, so you can kind of see that they're very similar in style. You can see here's the dialysate flow here through the hemofilter. There's replacement volume. You always have some volume going in. Both of them are pulling through the ultrafiltration coming back out in both of them. You have to have the patient's blood pressure is the pump. Over here on the CCRT, this has a centrifugal pump. Solutes removed by convection, no dialysate required over here. So you have dialysate here, this is convection. And certainly there's osmosis and diffusion occurring. Now, I'm not going into this, your textbook does. There are 4 different types of CCRT, but I just can't imagine that being on state boards, or that would help you in the long haul, just passing this test. You don't need to memorize those, but it is described in the book. So there's slightly different versions, veno versus veno arterial, and that sort of thing. But what I really want you to get is the concepts of what's going on here, not memorizing the 4 different types. So we're not testing you on that per se. Okay, so that's the overview of the types of hemodialysis, meaning IV access of some sort to act like a kidney. Now let's talk about peritoneal dialysis, another version. This was really hectic to take care of patients in the ICU on peritoneal dialysis. Before they had the machines that you put them on automatic, because literally every hour, actually every 15 minutes you had to be doing something. You'd put in the dialysate, then you'd pool for 45 minutes, then you'd drain for 15 minutes. So you could easily miss a 15-minute window and distracted with the other patient. It was very hectic. But now it's more mechanized. So in a way, it's not as much fun, but a little less hectic. But it's another way to remove solutes and fluids using peritoneal membrane as the filter instead of the mechanical filter with blood going through it on the side. What we use, it's a removal of solutes and fluids by diffusion through the patient's semi-permeable membrane, which is the peritoneal membrane. With the dialysate solution that's instilled, so you pour the dialysate in, the peritoneal membrane surrounded by the abdominal cavity and lines the organs inside your abdominal. So you got the space in there. It's not utilized for other stuff. Perfect for this. It's commonly used for acute renal failure because it's comparatively slow ability to alter biochemical imbalances. So you get a continuous treatment versus having to go in, lay at a table for a certain number of hours, and then go back to work. People can choose their types. This is, in a lot of ways, less invasive, but they both have problems. Time consumption-wise, what people do now is they'll do all their dialysating at night. They'll hook themselves up. I'll show you pictures in a minute. And it's doing frequent exchanges while they're sleeping, and then they may dwell a couple times during the day. So in a lot of ways, it can be better. The big problem is risk for infections in the peritoneal cavity with the tubing. So remove solutes and fluids using the peritoneal membrane as a filter. Tinkoff catheters is a picture here up in the corner. It's the brand of tubing. It's inserted in the peritoneal space, literally just floating in there through the anterior abdominal wall. So here's a picture. See, it's just on the belly surface. In the ICU, like I said, we have more rapid dwell times because the patient's more critical. Literally, it can be 1 hour, 15 minutes in, 15 minutes draining, and 30 minutes in, depending on what you're doing and your goal. High risk of peritonitis, and then you can't do it, so you have to move to hemodialysis. Catheter placement is usually done via surgery, and the dialysate solution dwells with a scheduled time in the abdominal. So you'll put this clear bag in, and it drains out a yellow bag with the ultrafiltration. Here's another picture of how the Tinkoff catheter goes in, just to give you another vision. Here it is. Here it is under the subacute space. Oop, how did that change? Sorry. And it's just floating in your abdominal space. So these can get clogged up. They can get little fibrin clots. They can get infected. Certainly it's imperfect, but it's pretty cool that it works. Available in 1 to 2 liter plastic bags with glucose concentrations of 1.5%, 2.5, and 4.25. So there'll be a prescription saying which type to use depending on how osmotically they want to pull out fluid. The electrolyte composition is similar to your plasma, and solution is warmed to the body temperature. I had used this once or twice for other reasons. For example, we had a guy that was hypothermic. He was on the side of the road and his temperature got really low after a car accident. He was out there all night and it got 20 degrees that particular night. Brought him in, and when you're warming people up, their tissue out in the periphery will be crystallized, right? They're starting to freeze to death. So you don't want to warm them up from the periphery in, or little crystals will break off and start floating away. And they will anyway, so you prefer to warm up from the inside out, so it kind of melts off the ice cube, so to speak. So we'll warm dialysate, put it in, and then drain it out. So it's an attempt to warm him up. And then, of course, put him on the ventilator, even though there's nothing wrong with his lungs, to warm him through the ventilator. And even then, the guy had a lot of arrhythmias. Those little ice crystals can cause arrhythmias when they go into those teeny coronary arteries. I mean, this is a young man. He was running and jumping in and out of VTAC and having PVCs. But it's used for other things as well. But generally, peritoneal dialysis. Here's just one more gentleman doing his own dialysis at home sort of thing. There's 3 phases of peritoneal dialysis cycle, and I kind of already explained that. There's the inflow, where you're filling. You're pouring it in. Solution infused over about 10 minutes. Then inflow, you clamp it close to prevent air from entering the tubing. Then you dwell. Diffusion, osmosis occurs. It sits in there a certain amount of time period. Duration of time varies depending on where the patient's at, what the need is. And then you drain again, 15 to 30 minutes. Now you may be facilitated by gentle massaging the abdomen or shifting the patient around to get it to drain better. Sometimes I've had patients on PD and they'll only drain on the left side. So you're constantly shifting them around. And Or they'll drain on their back and their left side, but not the right side. So you're having to adjust to get them to drain. What else? Peritoneal systems. Here's just some more pictures here showing, this is an automated machine. So here's somebody at their bedside setting it up, and then she's hooking herself up, and she's going to go to bed, and it'll do the cycles. They're called a cycler. It delivers the dialysate on a timed schedule. Times controls fill and dwells and drains. And just show you a picture here. Here's the bag going in, and here's the fluid in your cavity, and then draining out. So in continuous ambulatory PD is the manual exchange. You put a bag in, you clamp it off, disconnect it, you go shopping, go to the grocery store, come back, and then you may dwell it later. Certainly risks, complications, there's always complications. Infection, we said that. Peritonitis, we said that. Certainly scar tissue, so lack of flow. I had a patient who had he'd been on peritoneal dialysis at some point, had different issues with it. Then he got a kidney transplant. Then that failed, so he had a pancreas and kidney transplant. That failed. Pancreas lasted about 3 years, the kidney lasted 10, and then he wanted to do peritoneal dialysis again, but there was too much scar tissue. They just couldn't, with all the surgeries and the dialysis in the past, there was too much scar tissue. He had to go on hemodialysis. Excuse me. Oh, I'll drink fluid while we're talking about renal failure. Okay, if you're really quiet, can you hear the rain? It never rains in California, so it's like the perfect day. Anyway, what else can we tell you? A little bit about geriatric considerations. This is Grandma with her GFR of 30 and still trucking along playing with a granddaughter. Remember, 85 or high, and 100 to 100 something was normal. Normal renal declines owing to age. We said that about 35% of end-stage renal failures are age 65 years old older. Part of that just the aging process, and of course in America it's the diabetes, the hypertension, and the as well as aging. Of course, here it is. The most common diseases leading to renal failure in the older adult is hypertension and diabetes. Grandma here was a type 2 diabetic. Between her Dr. Peppers and her Whopper cheeseburgers, she never managed her weight or her eating. And ended up in, well, she's not renal failure yet. She's 87 years old, but she's been a type 2 diabetic for quite some time. So we said after 40, you lose function. Now, interesting, in the old elderly, even though they're losing function, you can see the glomerular filtration rate dropping, their creatinine levels may remain the same. So even with the declining GFR, because of the decreased muscle mass and hence decreased creatinine production, the creatinine might not go up as much in this population. Just a computer here. So the ability to concentrate and dilute urine is impaired as well because of the inability of the renal tubules to maintain the osmotic gradient in the medullary portion of the kidneys. So as you age, the function changes, but some of it makes you more tolerant. For instance, less muscle mass, less creatinine. I think those are the biggies on that one. Okay, let's move on to a little bit. We talked about transplantation, so just a little bit about kidney transplantation because it is so common. It's probably the most common one. Recipient selection, very much like we talked about in the transplant lecture. Contraindications, certainly other malignancies. If you've got cancer, we're going to immunocompromise you. It's not going to be a good thing. If you have underlying cardiac disease, chronic respiratory failure, extensive vascular disease, or unresolved psychological disorders. So typically what they'll do is want to fix the other stuff first before we go for a transplant. So let's say somebody needs a CABG. They need open heart surgery. They'd want you to do the open heart surgery before they do the transplant. They want you as primed as possible before they go in. The reason for the unresolved psychological disorders, we talked about that under the transplant lecture, is because we're going to put you on steroids, which can alter your personality in a negative way. So we don't want to make you even worse. And remember, somebody's going to die waiting. So you want to give it to the best person possible. It's a government investment, really. Because whatever we pay isn't covering all this. So you have to be selective because not everybody can just waltz in and get this done. A little more about kidney transplantation. Now we have live donors. They'll look at the HLA histocompatibility and the blood type. Nephrectomy is performed by the transplant surgeon. It begins basically 1 to 2 hours before the recipient surgery is started. The whole thing takes about 3 hours. It's a big surgery. I don't know that I'd volunteer. If one of my kids needed my kidney, I'm not so sure I'd be volunteering for it. I'm hoping I get too old before anybody asks me and they won't want it. Because you see family members do this, and I'm like, do they have any idea what a big deal this is? Anyway, but it's a beautiful thing. It's a wonderful thing. People do it. Sometimes you need to remove ribs to get adequate view of the kidney. There are laparoscopic donor nephrectomies, which is an alternative to the conventional nephrectomy. Better recovery from that technique. Primary method now of live kidney procurement. That's much more popular. Surgical recipient, donor artery is anastomosed to the recipient's internal, external iliac artery. We had one guy once that wanted to donate his child's kidneys, and the child just genetically had double vessels, and they couldn't do it. It was weird. It was a fluke. The donor vein is anastomosed to the recipient's external iliac vein. Urine may begin to flow, or diuretics may be given. So sometimes they start urinating right away. It's a 3 to 4 hour surgery. Postoperatively, close monitoring for renal function, certainly. Close monitoring of hematocrit, because remember, the kidneys tell the bone marrow to produce red blood cells. Urine outputs replaced with fluids, milliliter by milliliter per hour, so you match it to keep them balanced, neutral. Acute tubular necrosis can occur, so they may need dialysis for a while and maintain catheter placement for their hemodialysis lines. There's no guarantee it'll take right away. They maintain sufficient immunity to prevent overwhelming infection, which we talked about in the transplant lecture. And then, just to finish off our fun, entertaining talk here, joy, renal failure. Oh, need more water. Got a drink. Oh, and look, little wet shorty. He finally quit shivering, even though he's a little wet still. This is the guy that was barking in some other lecture. Anyway, little case presentation here to finish off the day. Ruby Wilson is a 75-year-old who had a recent history of severe renal infection, glomerulonephritis, leading to acute renal failure. So what do we find? Oliguria. Her urine output the last 24 hours was only 325 cc's. She gained a half a kilogram in the last 24 hours. Okay, so whenever you see those diet things on television, they say, "Oh, lose 10 pounds in a week." Okay, nobody's losing actual 10 pounds of fat. You didn't burn it off in a week. It's just water. So whenever you see somebody advertising that, that's not a good method. It's literally just water weight. So it's a scam. Anyway, neck veins distended. Breath sounds with crackles and wheezes, because where does fluid go? The class of least resistance. What a nice place to settle in your lungs, right? Generally, there'll be 3+ pitting ankle edema. Skin might be pale. Skin might be shiny and alert and oriented still in this particular patient. So what happens? Let's look at these laboratory values we found on this poor woman. Sodium was 155. Okay, so it's up a little bit. Her potassium on the high end, it's elevated because she's unable to excrete potassium in the urine. It's creeping up on us. Urine specific gravity is low, right? 1.008. She can't concentrate her fluids like she should. Okay, and then the BUN and creatinine creeping up simultaneously together. And you can see there's the normals here. And this is a typical lab value you might see on these two. Her fluids were restricted, is what we did, to less than 500 cc's for 24 hours. We bolused her with Lasix administration, trying to see if we can get her to diurese, get fluid off. Head of bed elevated to help her breathe more comfortably. We recorded her INO and started daily weights, and continued our physical assessment and vital signs serially and lab values. So this is your initial treatment on little Miss Ruby Wilson here. And did I ever tell you guys if I haven't told you this, it's just humorous, the positive jewel sign. Back in the 80s, about 80 years before the 1980s and the early 90s, certain names were very popular. You know, like now the Natalie Nicoles of the 1980s were the rubies, opal, jewels, and pearls of 80 years before. So whenever we got a patient in the hospital and their first name was ruby, opal, jewel, or pearl, that you'd always refer to as a positive jewel sign, and that told you that they were over 80 years old, because nobody named their kids that anymore. So they're all passed away now, so you won't be the positive jewel sign generation. I was. Anyway, so that finishes our renal failure lecture. I hope you guys have a nice day. Take these notes, read the chapters, listen to the lecture first, then read the chapters, taking the notes while you're looking at the chapters. It's really the best way to learn this. And I hope you guys have a nice day. And I don't know if you can hear it, but it's still raining, so that means hopefully I'll go to the bathroom and pee. Talk to you later. Bye.